All right, I see that our next speaker is here, Dr. Helen Chu. Dr. Chu received her master's in public health in epidemiology in 2012 from the University of Washington, where she completed a fellowship in infectious diseases. And Dr. Chu did her residency at Harvard Medical School, and she obtained her medical degree at Duke University. Dr. Chu's research focus is on preventive interventions against influenza, RSV, and emerging respiratory viruses such as SARS-CoV-2. And she conducts clinical and translational research on a large-scale community-based studies of respiratory viruses with a focus on vaccines, antivirals, and diagnostics. And she is also interested in defining clinical and immune correlates of protection against respiratory viruses and describing mechanisms of maternal fetal immunity against respiratory viruses. And she was instrumental in detecting the first cases of COVID in the United States when all of that first happened. So please welcome Dr. Chu.
Thank you for inviting me to speak to you today. My research is in respiratory viruses, and I've been doing a lot of work on vaccines and community surveillance for respiratory viruses for the last 15 years. But as part of the COVID response, one of the things that our group became involved in was really sort of helping to define long COVID here in Seattle, and then also as part of a large consortium in the United States. And so I was asked to give a talk about the research updates on long COVID. And so I will focus on that, but I'm happy to also answer questions about respiratory viruses and vaccines. Okay, and these are my disclosures. So in my talk, I will be going over the definitions of long COVID, the risk factors for long COVID, and clinical manifestations of long COVID, talking about what we know so far about the mechanisms that underlie different phenotypes of long COVID. And that includes the cardiac phenotype, the pulmonary phenotype, and then the neurologic phenotype. And then finally, I'll talk about some of the prevention and treatment trials that have now started and some of the early data that is starting to come out over the course of the last several months in developing ways to both prevent and also to treat long COVID. Okay, so first we'll start with some terminology. In most of this talk, I will either be referring to this as long COVID or PASC, which are the NIH, and then also just the general public definition. CDC has a different way of defining it. They call it post-COVID condition, and then in the lay community, it's also referred to as long haul COVID. There are also different definitions for how long it lasts. So the WHO states that long COVID is defined as having persistent symptoms at least 3 months after the onset of COVID-19, and then that the symptoms need to last for 2 months. And then the CDC defines it as symptoms that develop during or after the COVID-19 infection, but then are present 1 month or 4 weeks after infection with no alternative diagnosis. And then recently, we now have an ICD-10 code for long COVID, and it's U09.9, which is unspecified post-COVID condition. So the way that we think about long COVID is that it really is sort of part of the entire disease trajectory of COVID-19. That first, when you are inoculated with the virus, it enters into your respiratory tract. It potentially disseminates to many parts of your body. And at the time of initial infection for those first several weeks, you have what we consider acute COVID-19 infection, which I'm sure all of you know how that presents. What happens afterwards is that some people go on and they have a complete recovery from that acute COVID-19 illness. And then a certain proportion of people, depending on the population that we study, then go on to develop lingering symptoms that then persist for what it seems like now 2 to 3 years after acute illness. And the set of lingering symptoms is really protean. So you think of it in a couple of different ways, but I like to think of it sort of by buckets, and that's usually how the WHO thinks of it as well. So you have the first top bucket, which is quite non-specific, but it's fatigue, a decrease in the quality of life, having extreme muscle weakness and joint pain to the point that it's debilitating and you're not able to do your job or go to school. The second bucket is sort of the pulmonary bucket, where we think of people having persistent dyspnea or cough or an oxygen requirement. The third bucket is the cognitive, psychiatric, neurologic bucket, and that's persistent anxiety and depression, sleep disturbances, People have PTSD. They have something called brain fog, where they have difficulty focusing and concentrating for long periods of time, and headaches. And then there's the cardiac bucket, which is often persistent chest pain and palpitations. We also know that SARS-CoV-2 causes inflammation of the blood vessels, especially the small blood vessels, and causes thromboembolism. So people present with microemboli, and then they have DVTs and pulmonary emboli. People have chronic kidney disease, and then there's hair loss, which is a fairly significant dermatologic manifestation of long COVID. And I think one of the things that we've now learned over the last 2 to 3 years of research is that when people come in with these symptoms, they either had them at the beginning, or oftentimes what's happening is that they actually fully recover from their acute illness episode. And then over the course of several weeks to months, they start having these symptoms. And then that frustratingly for a lot of these patients, it waxes and wanes. So they'll have good days, they'll have bad days. There will be times where it seems like, okay, all of this is better, I can go on with my life. But a couple of weeks or months later, it all comes back. And it's become this chronic waxing and waning debilitating illness for a lot of people who are unfortunately affected by long COVID. So this is the symptom profile. These are the most common ones that we see: fatigue, dyspnea, chest pain or tightness, cough, loss of sense of taste or smell. The neurologic, psychiatric, cognitive ones like the brain fog, the anxiety and depression, and the difficulty with memory and concentration. When we first started defining this illness, it became clear that there was significant overlap with people who had something called post-ICU syndrome, or PICS, which is new or worsening impairment in physical weakness, cognitive, sort of the ability to think and clearly and to make good decisions. And this all happened after critical illness and then persisted beyond discharge from the acute care setting. So it was thought initially, well, this is happening only in people who are severely ill, acutely ill, who are in intensive care unit level care. And then in most individuals, this was not going to happen. But what we found out later over the course of the next several months is that actually this was not the case. So we now know that long COVID actually is not that different from many post-viral syndromes that we have seen with other new pandemic viruses that have emerged or that have infected humans. So for example, with Ebola, with SARS, and with MERS survivors, they have similar patterns of these persistent symptoms. So if you look at some of the case series of people who had Ebola who have now been followed out for several years, you can see that a lot of them have symptoms of fatigue, of joint and muscle pain, headache, and then a lot of ocular problems. We know that people who have MERS have chronic fatigue, and about 50% of them have that at 1 year. And then after SARS-1, there have also been reports of persistent shortness of breath, fatigue, reduced quality of life, and then also mental health issues that have persisted. There's also a lot of overlap in the syndrome with myalgic encephalomyelitis or chronic fatigue after viral illnesses like chikungunya, Lyme, or ABV. And so these types of syndromes of fatigue and myalgias and problems with memory and concentration and joint pain and ocular problems and headaches, this seems to be part of a post-viral syndrome that is actually not specific to SARS-CoV-2, but has been seen with many, many viruses, but just have not affected the broad swaths of the population for it to become such a global problem. So when we first got involved in this, so we had been part of the initial COVID response here in Seattle. And one of the things that we did was that we enrolled individuals who had COVID-19 infection, starting with the first US patient, and then now with about 600 patients enrolled. And I had been doing research along with my group on understanding the immune response to respiratory viruses. So when the first US patients arrived in the United States in Seattle, we were asked to help enroll those individuals into studies where we could collect samples from them and send them to the NIH for development of vaccines. So we did that. And then what we realized with these individuals was that they were actually complaining of persistent symptoms well past the point at which we thought symptoms would have resolved. And so we started asking them questions about persistent symptoms and impact of quality of life over time. So we had them critically, many of them were mildly ill or had asymptomatic illness. So most of the people that we enrolled were not hospitalized individuals or those in the ICU. And so when they first came into our study, we had them complete an initial questionnaire, either when they were still hospitalized at the time of illness or at day 30 after symptom onset when they were first allowed to come in to see us. And then we had them complete a follow-up questionnaire at 3 to 9 months after illness. And this was based on a study that had been done in Italy that had just been published. And we contacted those authors and we asked them for a copy of their questionnaire and the scale that they use to assess for persistent symptoms. So we asked them questions about activities of daily living, about the kind of medical care they were accessing, and then their quality of life using this scale, the Euro Quality of Life Visual Analog Scale, which is shown here on the right. And what you can see here is that it asks you to rate your health from worst to best. And this was what was used in the Italian studies and actually has become sort of the standard of care for long COVID studies across the world. And so remarkably, in our study, we had 234 people enrolled at the time, and 177 of them completed this follow-up questionnaire for us, so 76%. And we also looked at healthy controls who did not have COVID-19 infection, and they also completed the questionnaire. And we found that in these individuals who had mild to moderate disease, who were never hospitalized for their illness, that about 1/3 of them had persistent symptoms at the 6-month mark, and that these persistent symptoms increased with the age of the individuals from 27% in those who are 18 to 39 up to 43% in those who are 65 and older. And so this was the first description in the United States of an outpatient cohort with long COVID symptoms. And it became sort of the impetus for a lot of subsequent work that happened. And so this is where you can see the comparisons of the symptoms in these individuals, both at their acute enrollment questionnaire, shown here on the left in the gray and the blue, and then also at follow-up. So these were in the dark orange and in the light orange. And what you can see was that the most common symptoms of follow-up at 6 months were fatigue and then loss of sense of taste or smell. And interestingly, that loss of sense of taste or smell was a write-in. We didn't know back then in 2020 that was actually going to be a persistent symptom. And so, but people who were completing this questionnaire had a free text box and they wrote in things like, I still can't smell, I still can't taste, and I'm still continuing to lose my hair. And so we were able to capture that information, not as well as we did in follow-up questionnaires, but at least at this initial time point, we had this information. There were also several studies published from other countries. There was the study in Italy, and then this was a study in China that I wanted to highlight because of the number of individuals that were surveyed in this study. So these were people, unlike in the United States in our study, these individuals were hospitalized, and they were able to follow up 1,733 of the 2,400 discharged patients from the initial Wuhan epicenter of the pandemic. And what they did was they asked them about the symptoms, and then they also did pulmonary function testing and the CTs of their chest. And remarkably, they also had a significant number with symptoms at 6 months. So 75% had at least one persistent symptoms at 6 months, and greater than 50% had abnormal chest imaging at 6 months. What you can see here is the types of chest imaging done on the results from the chest CT done here on the bottom, and then on the top you can see the lung function in those who had this follow-up. And again, the main point to be made here is that people, even those who did not express having persistent symptoms, still had abnormal PFTs and abnormal chest imaging at 6 months, suggesting ongoing damage to the lungs as a result of their early COVID infection. We did not do this in our study. We were not funded for this, but people have done this in the United States subsequently and have also found similar things where they've seen abnormal PFTs and abnormal chest CTs in people who state that they are asymptomatic, but clearly continue to have abnormalities on this testing at 6 months, 12 months, and now up to 24 months. So this group of investigators then followed up these individuals out to 2 years. And so what they found, again, like the proportions at the 6-month mark, that that patients continue to have symptoms at least 2 years after infection, and that this frequency of persistent symptoms was significantly higher compared to controls. And that the most common symptoms that they saw in their cohort was sleep disturbance, fatigue or muscle weakness, hair loss, and joint pain. And then again, continue to have abnormal lung function. And then at this time point, they did 6-minute walk tests as well. That's all of that data that I've presented so far is from adults. The data in children is starting to come in, but it continues to be sparse compared to the adult data. I would say that overall, we know that the risk of long COVID in children is lower than in adults. And this is a meta-analysis of a lot of different studies put together by Zimmerman and Allen that was published late last year, where you can see that the proportion of those with long COVID was ranged from negative 0.5% to 3.5%, with one outlier at 13%. And that generally the consensus is that 3% of individuals, 3 to 4% of children do go on to develop long COVID. And that proportion is different and lower than probably the 6 to 10% that we see in the adult population. So how does PASC in children or long COVID in children present? So there was a study that was done a couple, I guess now a year and a half ago, where they published the results in JAMA, and they looked at children who are either seropositive or seronegative. And they found that 4% of individuals had at least one symptom lasting beyond 3 months, and that the most frequently reported symptoms were fatigue and then poor concentration. So very similar to the adults. We do know, however, that despite children not having as high a proportion of long COVID, they do develop MIS-C, which I'm sure all of you are very familiar with. And we don't quite know what the long-term consequences of MIS-C is, but there is, as we know in adults, that there is this evidence of inflammation and aberrant immune response that is occurring in response to the SARS-CoV-2 virus in both adult and pediatric populations that seem to manifest in different ways. And this was just a nice study that was published that highlighted what was known about MIS-C in children at the time, and really sort of reviewing that it happens in children. You have fevers associated with MIS-C, and then critically you have evidence of a multi-system inflammation, and that is really the marker of MIS-C. And many children do go ahead and recover fully from MIS-C, but it does show that children are triggering some sort of inflammatory cascade in the same way the adults seem to be triggering, but it just may be manifesting in different ways. So this is a slide that was actually just published a few weeks ago, looking at performing a medical record review of from children's hospitals. I think it was 9 children's hospitals in the United States. And here what they wanted to do was to compare children who came in and they were tested for COVID, and they looked at those who tested positive versus tested negative. And that they found that 4% of children with lingering symptoms were attributable to COVID-19 between 1 to 6 months after infection. So very similar to some of the early data that I showed. So the symptoms in children included fatigue, chest pain, chills, loss of taste or smell, myocarditis, and then what, interestingly, the way they captured this, they called it use of cough or cold medicine, because they weren't able to accurately capture cold-like symptoms. But what they were noticing, very interestingly, was that children were having increased episodes of bronchiolitis, of bronchitis, of upper respiratory illness after their COVID-19 infection at increased rates in those who had COVID compared to those who did not. Unlike adults, they were less likely to have headache or brain fog or persistent pain, but they were more likely to have hair loss, skin rashes, diarrhea, and then abnormal liver function. And that the risk factors for persistent symptoms, long COVID in children, were in some ways very similar to the adults. So being critically ill, having comorbid medical conditions, and then in children in particular, it's the younger age groups that are a higher risk of long COVID. Whereas in the adults, what we see is that you actually get more, your risk of long COVID is much higher the older you are. And here's a nice figure from this paper, and all my slides will be available to you, but essentially showing the types of symptoms that we see in this electronic medical record review of long COVID in children, and really this loss of sense of taste and smell, the loss the hair loss and the chest pain really being predominant features of what long COVID looks like in children. As a follow-up to some of the work that we had initially done, really sort of just understanding what is the symptom burden in individuals at 6 months who had COVID infection, we worked with our collaborators at the Institute for Systems Biology and Swedish Hospital here in Seattle, and this is Jason Goldman and Jim Heath. And we took our cohort, which is called haärvi, and then we combined it with another cohort called NCOV, which they had enrolled from Swedish, as well as a set of healthy controls. And we took all of those individuals and we applied what's called a systems biology approach. So we tested them for antibody, we tested them for autoimmune markers, we tested them for viral load for all these different viruses, and then we looked at sort of their B and T cell immunity. And then we profiled them to really sort of dial down on what are the factors that increase your chance of long COVID. And so we published this in Cell last year, and then it was featured in an article in the New York Times, which I've put here in case you want to read it, about sort of identifying these are the predictors that are associated with development of long COVID in individuals who were enrolled at the beginning and then followed prospectively over time. So the factors that we identified were EBV viremia at the time of initial illness, so Epstein-Barr virus viremia, SARS-CoV-2 RNA-emia, so having SARS-CoV-2 virus in the blood, type 2 diabetes, and then having the presence of autoantibodies. So if these four factors were present at the time of initial diagnosis with COVID-19, you are more likely to go on to develop long COVID compared to those without these factors. And I think if we look at this, it makes a lot of sense. Having virus in your blood, SARS-CoV-2 virus in your blood, is usually a marker of more severe illness. And EBV viremia, we think, is potentially due to reactivation of the virus, as we see with people who have critical illness. And then we do know that type 2 diabetes increased your risk, not only in this study, but in other studies. But the autoantibody part was quite intriguing to us of why is it that having the presence of autoantibodies is causing this persistent set of symptoms. And then we also found lower cortisol in those who went on to develop neurologic symptoms. So that is really all we know so far, I think, about both the clinical presentation and the factors that may predict development of long COVID. There is a lot of research that's being done. There have probably been studies published in the last 2 or 3 weeks that I don't know about. It's hard to actually keep up with all of the progress that's being made. But I think the main point is that it does affect a lot of the population. It affects children less so than adults, and children may present slightly differently. And that we're really starting to do the early work to understand what are the factors that are associated with development of long COVID in populations, so that we can potentially target the high-risk groups and prevent long COVID. So here I wanted to go over the possible mechanisms for why long COVID is happening. So there's a couple of different thoughts, and I'll show you some of the data supporting each of these. There's still no consensus on what is the cause of long COVID. There's no good animal model, I think, is part of the reason. And also just because the way that long COVID manifests in different people is so different, it's really hard to say, this is long COVID and this is not long COVID, and therefore this is what we expect to see pathologically that corresponds with it. So the first thing that people think is happening is viral persistence. And so that's that there's a reservoir of replicating virus that is associated with ongoing inflammation. The second is cardiopulmonary disease related to pathophysiologic changes, and then microvascular disease. So this idea of having these microemboli that are leading to trouble breathing because of probably subclinical pulmonary emboli, and then also potentially leading to the strokes, and then leading to a lot of the some of the autoimmune features that we're starting to see. And then this idea of the neurologic sequelae being also due to this idea of microvascular ischemia due to these microemboli. And then critically, actually, a really interesting paper that was just published looking at the role of potentially inflammation in the CSF driving some of the neurologic symptoms like the brain fog. And I'll go over that study. So the viral reservoir hypothesis, the idea that there is persistent virus that's driving this inflammation. And this was really based on a couple of studies. The first one is an autopsy that was done in people who had died of COVID-19. And they found viral replication in multiple reservoirs, including in the lungs and extrapulmonary tissues early in infection. And then they also found persistent SARS-CoV-2 RNA in places like the brain up to 230 days after symptom onset. There have been other studies that have found viral shedding in the GI tract well past the period when the virus is no longer in the lungs. So the issues and the questions with sort of these studies is the presence of the virus indicative that there's ongoing replication and therefore an immune response to that ongoing replication, or are we just detecting fragments that are there? And that's very challenging to do, to be able to differentiate between what's replicating virus and versus what's just fragmented virus that's left over, because PCR is such a sensitive technique that really I think it's very hard to do well without a good animal model for long COVID, which we currently do not have, where you would actually be able to challenge the animal and then see what happens. For the cardiovascular complications of long COVID, a lot of that is thought to be due to these, to both the fact that it has a tropism, that SARS-CoV-2 has a tropism for the ACE2 receptor, which is present on blood vessels, and that it's also leads to these microclots. And then the microclots are sort of driving this persistent inflammation, the lack of oxygen delivery to the cardiac tissues, and then a lot of like the chest pain and the shortness of breath symptoms that people experience after their COVID-19 infection. And then the neurologic sequelae. So this is actually a really interesting story. So researchers at Stanford who were studying chemo brain realized that a lot of the symptoms that children and adults were experiencing due to COVID, this brain fog, were very similar to individuals who had received methotrexate therapy for chemotherapy for their cancer. And so they thought, well, if methotrexate causes the same sort of phenotype of brain fog as COVID-19, is there some way to unify the two? And so what they found was that they then they looked in humans who had COVID-19, and then what they found that on imaging, they had evidence of inflammation in the subcortical white matter. And then when they looked in their CSF, they found elevated levels of cytokines, including CCL11. And that is actually very similar to what is seen with methotrexate. So is there some sort of common pathway by which methotrexate, which is a fairly toxic agent, and COVID-19 are both driving this inflammatory response in the CSF and in the brain that's leading to these symptoms of brain fog that are and then persistent neurologic or CNS inflammation that's causing the people to have sort of debilitating illness and inability to concentrate after their initial infection. So that's all we know so far. There's also a lot of work being done on autoantibodies, but I didn't want to cover that today because the data is so controversial right now, and I think that it's really hard to tease out. There are studies showing both things, both that autoantibodies are associated with development of long COVID and that they are not. That it's really, I think we're still sort of waiting to figure that out, and it's just there's just too much data to really sort of be able to bring it all together. So I wanted to then spend a little bit of time actually going over what we know about prevention and treatment, because I thought that might be most relevant for this group. So the way that we handle long COVID, at least in the adult clinics, is that it's a multidisciplinary approach. That there is a COVID-19 clinic that's at the University of Washington that's led by Dr. Jana Friedli of physical medicine and rehab. And it's a PMR clinic that then integrates care for these individuals along with all of these other subspecialty groups. So the pulmonologist, the cardiologist, the hematologist, the nephrologist, primary care doctors, and then the neurologist, the psychiatrist, and then critically, the therapist, the occupational therapist, the physical therapist. They have played an enormous role in the rehabilitation of people with long COVID. Um, so what do we know about prevention of long COVID? I think initially we didn't know this, but over the last couple of months, I think we have pretty good data to show that vaccines do protect against development of long COVID. The numbers sort of range based on which study, but I think this one is actually a really good one. This was a study that was done in the UK, and what they did was they have people that they have been following for a long period of time, that they've been contacting through text message, and they've been following them at the population level. So it's, hundreds of thousands of people. And they've asked them, after your COVID-19 vaccine, did you develop persistent symptoms that lasted more than 4 days or 4 weeks? And they compared those against people who did not receive the vaccine. And what they found was that the COVID-19 vaccine was associated with a 41% decrease in the odds of developing long COVID symptoms at least 12 weeks later, compared with not being vaccinated. And the numbers are shown here on the bottom, but here 9.5% of 3090 breakthrough SARS-CoV-2 infections in those who had been vaccinated versus 15% in those who were unvaccinated. So it's not zero, I think, is the main point, is that you can get a vaccine and you still can get SARS-CoV-2 infection and you can still have persistent symptoms, but your risk is decreased by 40% if you get if you're vaccinated versus unvaccinated at the time of your SARS-CoV-2 infection. And this is just their graph, which here on the bottom on the left, the symptoms lasting greater than 28 days. And you can see that those who received a vaccine had lower risk. So to the left of the one dashed line, had a lower risk of having persistent symptoms at 4 weeks, which is how we define long COVID according to CDC. The other question that often comes up is do we see a difference with these different variants? Are you less likely to get long COVID with later variants versus earlier variants? And indeed, again, a study from the UK, because they have such good community-based studies, is that you can see a risk of long COVID being lower in those who had Omicron variant compared to those who had Delta variant. And critically, this was after adjustment for vaccine status. And I think, the question is it a property of the virus that's leading to this, or is it that people are getting less ill after their because they've already had quite a degree of exposure to vaccines and then probably to asymptomatic natural infection, that then their risk is decreased? But it's not clear. But I think that we as researchers are definitely seeing that as time is passing, that those who had COVID very early in the pandemic are much more likely to have long COVID than those who are getting it now after they've had multiple doses of vaccines in them. So whether or not that's virus specific or immunity specific, it's still to be determined. But they did show in this study that Omicron was less likely to cause long COVID or to be associated with development of long COVID compared to earlier variants like Delta. One of the very frustrating things, I think, for the field and for the patients who enroll in our research studies is, what can we do for people who do have long COVID, and what are some things that we can treat people with to help them get better from what has become a chronic debilitating illness? So there's this thought that the prolonged inflammation, the viral persistence, is potentially part of the mechanism that drives the development of long COVID. And so potentially treatment with antivirals, with monoclonal antibodies, with immunomodulating agents may reduce this. And so one of the ways that you can assess this is that you look at those people who were in those early treatment trials, those early randomized clinical trials of these different therapeutics, and you can see what happened to them. You can see what happened to those who received Paxlovid or did not receive Paxlovid, those who got remdesivir versus those who did not get remdesivir, and see if that had an effect on development of long COVID. The other way to look at this is you take the people who have long COVID right now and you try to give them those types of treatments, with the idea that potentially that treatment of persistent viral replication is going to help with reduction of ongoing inflammation and then reduction of the symptom profile. And I think both those approaches are happening. And I'm just going to highlight a few of the studies that have been done. Before I do that, I did want to go over some of the challenges in these clinical trials. As I told you earlier, the case definition remains nonspecific. There are over 100 symptoms that are associated with long COVID. These symptoms wax and wane. And there's often a lot of challenges in deciding what is our appropriate comparison or control group for our studies. And we spent a lot of time talking about this is the control group somebody who is never infected? Because that's not realistic anymore, and that's not actually the population. So it's not, and those people are unicorns. So they're very difficult to find, and they're not representative of everybody else. So who is the right control? it's challenging because there's no clear biomarker as a disease correlate. Remember, I showed you that we found these 4 factors that are predictive of development of long COVID, but there's no one slam dunk test that you can do. And you can say, well, this person has long COVID, and this is the biomarker that's evidence of that. We don't have like a CRP or a SED rate or D-dimer. None of those things have like really sort of been shown to be diagnostic of long COVID. To be able to really study long COVID well, you need a coordinated approach and consensus on enrollment criteria across multiple centers, which is very difficult because a lot of people have different opinions. And then also funding up until very recently has been quite limited. Only recently has NIH put out funding announcements for interventional studies to study things that you could do to either to treat or to prevent development of long COVID. So these are the list of the therapeutics that are currently under investigation. So there are anticoagulants to address the microemboli. There are anti-inflammatory drugs to address the persistent ongoing inflammation, both peripherally and in the CNS. There are antivirals like molnupiravir, remdesivir, and Paxlovid, which are thought to maybe shut down viral replication as a potential driver of the ongoing inflammation. Antihistamines to deal with sort of some of the inflammatory things that are manifesting as long COVID, and then also antidepressants and therapeutic vaccines. So this just came out, I think, a few weeks ago. But this is a really interesting study. I would caveat it by saying that it's only on medRxiv. It has not been peer reviewed. It really just came out maybe in the last week. But this was a study where they looked at Paxlovid. And this is an observational study. It was done at the VA in St. Louis, I believe. And they looked at 56,000 patients who had tested positive for COVID-19 between March and June of 2022, who had one risk factor for severe disease. And then they compared those who did and did not take Paxlovid within 5 days of their positive test. And they found that if you took Paxlovid, you were 26% less likely to develop long COVID than those who did not take Paxlovid. And then when they looked at the different subgroups, the vaccinated, the boosted, the reinfections, they found that this trend held. The limitations of this very, very early result is that this is an observational study. This is a very high-risk cohort. It's veterans. And that this was based on electronic medical record review. So we, as well as others, are part of a consortium, which I'll be describing to you, where I think this will be studied a little bit more prospectively in an RCT format. This is the figure from that paper. So what you can see here is that here's figure 1 on the left, and you can see that people who received Paxlovid were less likely to develop PASC. They were less likely to die, they were less likely to be hospitalized, and they were less likely to have a composite of death or hospitalization. And then here I've pulled out the figure that really shows the difference in long COVID and those who did and did not receive Paxlovid. And you can see that there's quite a difference. In the control group, the risk of long COVID is higher, and then and those who received the Paxlovid, which here has its generic name of Nirmatrelvir, sorry, I'm not used to pronouncing that, are less likely to go on to develop long COVID. The other thing that has been in the news lately is metformin. The idea of metformin potentially having a treatment effect in prevention of long COVID. Remember, I talked about how type 2 diabetes is a risk factor for development of long COVID. So this was a study that had been done by David Boulware's group at University of Minnesota, where they enrolled individuals, adults, 1,135 adults, and they enrolled them into 3 treatment groups for their initial SARS-CoV-2 infection: metformin, ivermectin, or fluvoxamine. And what they did was they compared each subgroup against its control, so a placebo control. And what they found was that when they followed up these individuals over time, that they were less likely to develop long COVID in the subgroup that had received metformin, 42% relative decrease in the incidence of long COVID, as compared to a 36% increase in the fluvoxamine group. And so again, this is a medRxiv, so it's not peer reviewed. The number of individuals is quite small, only 1,100. And then these are also individuals who had been enrolled early in the pandemic, so a long time ago, at a different sort of when long COVID looks different than it does now. And so I think both of these are suggestive that there may be an effect of Paxlovid or metformin early in treatment of COVID-19 that could have an effect in decreasing risk of long COVID subsequently. But the randomized clinical trials to definitively answer this question have not yet been done. So the consortium that we're part of is called the Recover Consortium. It's an NIH-led collaboration between multiple sites in the United States, including the University of Washington, Swedish, and Institute for Systems Biology, all here in Seattle, and as well as Providence. And then we are enrolling individuals, several hundred at our sites, and along with thousands of individuals throughout the United States to really understand long COVID. So the overall goal of the trial is really to understand the incidence and the prevalence of these symptoms, to understand the biological mechanisms underlying the pathogenesis. So one of the things that we do in our study is we collect a lot of baseline labs and studies. And we conduct a lot of baseline studies in these individuals, and then we repeat them over time. And the idea is that that really this observational study will give us sort of the framework to both understand what symptoms look like in a well-defined, rigorously followed cohort, and then also hopefully that over time this will become the structure in which we'll do our clinical trials. And I would say that, as an academic investigator, I feel like the NIH has focused very much on these observational studies rather than treatment, but it does seem like things are now starting to change, and there is a large shift towards treatment trials. And so this is the treatment trial that has been proposed. It's still early days, but the idea is to do a clinical trial of Paxlovid. This is a multi-center, multi-arm, double-blind RCT. And then the idea is that you would enroll people and you give them either Paxlovid or ritonavir plus placebo, which is, I thought, an interesting comparison arm. And then the primary outcome is on symptom-specific outcomes. And this is in individuals who have already known persistent symptoms. So as opposed to people who received it early in the course of their initial illness to prevent development of symptoms. So we'll see what this shows. I think there's certainly, value in doing this type of study. I think it'll also be interesting to look at some of the analyses of the follow-up of the RCTs of early Paxlovid treatment at large scale to see if early treatment or delayed treatment has an effect on either prevention of development or treatment of long COVID. This is another study that's being done in the UK. It's called Stimulate ICP, Symptoms, Trajectory, Inequalities, and Management, Understanding Long COVID. And they're doing a similar approach. They're enrolling at 6 sites in the UK from long COVID clinics. They enroll adults who have new COVID diagnosis. And then they have a stepwise approach where they're using a variety of agents, but including colchicine, famotidine and loratadine, and then rivaroxaban to sort of deal with the inflammatory piece as well as the embolic part of long COVID. I think I've covered a lot of information, and I'm happy to take questions. But essentially, PASC or long COVID is common after SARS-CoV-2 infection. Symptoms are now present out to 2 years, and now we're starting to see data that they're actually present out to 3 years. There is a decreased risk in children. That we think that there are clear risk factors that associate with development of PASC, including viremia with SARS-CoV-2, viremia with EBV, the presence of autoantibodies, and then diabetes type 2. That there's this idea that there is persistent inflammation and potentially the presence of a viral reservoir that may be driving this development of PASC, that vaccines are protective, that risk of PASC decreases over time with the novel variants, and that studies to date have been mostly observational and have shown an intriguing effect of Paxlovid and metformin. But really, we need to wait for those clinical trials, especially of the Paxlovid and the remdesivir and probably some of the other antiviral trials like molnupiravir to really understand whether or not they may have an effect in both decreasing risk of development or treatment of long COVID. And that is it. Here's my email if you want to ask me any questions. And then we have a website where we focus on all of our long COVID work, which is chulab.org haärvi. And you can go there and it covers all of the studies that we've done. So thank you.
What type of long-term symptoms or new diagnoses have you seen in youth, specifically teens? And have we seen an increase on more neurological issues?
Yes. So this idea of difficulty concentrating and fatigue has been an issue. So I'm not a pediatrician; I'm an internist, but I see young adults, and that is a group where this phenotype of like the inability to concentrate and get their work done, their schoolwork, attention issues, that has really been quite dramatic in this group.
Great. And then has there been a decrease of long COVID symptoms with patients who have had newer strain of the COVID-19 virus?
Yes, yes. As Omicron is associated with less long COVID than Delta. I don't know that people have looked at 4.5 or XBB yet, but I imagine as time passes and in general, as people have less and less severe disease, we will continue to see the prevalence of long COVID or the incidence of long COVID go down.
All right. And then would you describe the difference in initial COVID virus and the current variants, as well as the difference in respiratory symptoms and long-term respiratory effects? I think you kind of touched on this a little bit.
Yeah, I think what we know now, probably more than anything else, is that really sort of having a vaccine in you and having seen it in some way beforehand helps your immune response handle it so much better, not only initially, but in the long term. So it's not so much which virus, but really, did you get your virus before or after your vaccine?
Got it. Is there maybe just a follow up? I know some people may not have finished their series of vaccines. If it's just one dose versus the two or like the three with the boosters, is there any correlation
I don't
if
think
they were to
so.
get
I
the
mean, between
no?
how many doses you've gotten in, no, I don't think I've seen those studies actually. But I get my sense is that the more vaccine doses you have, especially the more breadth, right? So if you have like the
Mhm.
bivalent booster, as well as the initial Wuhan vaccine, then that just helps your immune system handle the virus better. And any sort of better handling of the virus seems to decrease your risk of long COVID. But I haven't
Thank
seen the
you.
data.
Okay. And then is there data suggesting COVID viral
Yes.
infections triggering autoimmune syndromes? Yes.
Yes. Yes. Oh, yes. There's a ton of data showing sort of a lot of new diagnoses of autoimmune syndromes happening after long COVID. It's I haven't seen any good systematic reviews lately, but we see it. We've seen a ton of it. Just new diagnosis of a lot of these rheumatologic issues that are coming up.
Hmm, interesting. And then is it unique for this COVID virus to cause these problems long term, or is it that we've never seen a virus infect so many people all at once to see this impact?
Yeah, so I think this speaks to sort of the idea that we saw this with Ebola and we saw this with MERS and we saw this with SARS-1, but it just didn't affect broad swaths of the population, or probably it didn't affect, frankly, the population that we cared about. That we as a, I feel like things that happen in sub-Saharan Africa don't get the attention that things that happen in sort of the West get, and so there's pretty significant debilitating illness in large groups of the population with Ebola. It's just not well publicized.
Hmm. And then does the risk of long COVID reduce further more with recent vaccination? Oh, sorry, I think I might have just basically asked that same question
Mhm.
um, earlier. How about this one? What is the data on increased risk of developing long COVID after multiple infections?
Yeah, you still have, I think the risk is there, unfortunately. The idea that you can get one infection and then be spared and then get a subsequent infection and develop long COVID, that is happening. People are definitely getting that. I don't know what the incidence is to give you precise numbers, but it is certainly possible.
Okay. Um, think, okay. Study of metformin. This was given in regardless of participants having type 2 diabetes, and then proposed mechanism of action to reduce severity or the sequelae.
Yeah, that's a great question. Yes, it was given in people without diabetes. It was given in people who are, I think, older and obese and overweight. And so maybe they were pre-diabetic. I'm not sure. Again, I think the idea of metformin sort of being something which helps tamp down inflammation is a thought of how it works. But metformin is used for a lot of things that are not diabetes type 2 specific, like polycystic ovarian syndrome, and so it's hard to know what the effect is. But that was not that many people. It was 1,000 people, of which, 1/6 of them got metformin, 1/6 of them got control, and that was the comparison. I don't know that I would sort of use that to make a decision right now. I think we have to wait for those trials. Um, it makes a lot more sense for me that Paxlovid has an effect, because that intuitively you think, okay, well, the virus is replicating and that's driving that inflammation. And so I would say that, if you were to choose to do something right now, that early Paxlovid treatment seems to, that makes a lot of sense. And the numbers from those studies are much, much bigger. So.
Thank you for that. And then the possibility of viral replication in a reservoir post-acute infection. How common is that in viral infections, and do other viruses do this?
Yeah, Ebola does. Ebola replicates in the eye. Ebola replicates in a lot of different spaces. Probably other viruses do too, but we just don't look for it. So I think there's this idea of now starting to study all of these other respiratory viruses. I mean, when we think about RSV or flu, especially flu in older adults, people get hospitalized with their flu infection and then they dwindle afterwards. And this idea of long flu is really starting to, become better studied. And then if you think about all of the other things that we now know happen after an initial viral infection, and the increased risk of myocardial events, the increased risks of strokes, how much of that may be related to viral replication beyond what we had expected in places that we're not looking. So I don't know. But certainly it exists for Ebola, hasn't, and for chikungunya, hasn't been studied for the other viruses so well.
Thank you. And then do these results apply to COVID patients who are asymptomatic as well?
Yes, they do. That was one of the early findings, that even if you were asymptomatic, you could still develop long COVID. You're much less likely to do so because the risk of long COVID increases with the more severe your initial disease was, but it has been seen in people who are asymptomatic.
And are there any trials for pediatric long COVID? And how can we support or advocate for our pediatric population that are struggling?
Yeah, it's really frustrating. I think that there are, so the Recover Consortium that I described is for adults, for pediatric populations, and then also for pregnant persons. So people can enroll in those studies. I don't know if Seattle is an enrollment site for the pediatric arm of the study, but it is being studied, certainly. And some of that data that I presented from the more recent JAMA paper, the 2022 one, that one actually came out of the Recover Consortium.
Yeah. Oh, sorry. Okay, sorry, just getting back to the page. Has there been studies on SARS-CoV-19 causing type 1 diabetes in children? We just had to talk about type 1 diabetes.
Yeah, I think there have. I'm not as up to date on that literature, but I remember reading that. But I'm not the right person to ask. I feel like that's not my area of expertise. I probably know less than all of you do. I just read it in the newspaper, just like everybody else. So.
All right, maybe some follow-up on our end for that one. Can you address the loss of smell and folks are curious about treatments for the loss of smell?
So there is the idea with the loss of smell. So first of all, we know that the earlier variants were associated with a greater risk of loss of sense of taste or smell than the later variants, and that has to do with the inclination of the viral variant to invade sort of the nasal epithelial cells and the tropism for the different parts of the respiratory tract. And so that was a super interesting finding. I remember that the Omicron was not as likely to do that. The treatments, I mean, there have been a lot of treatments. It's usually coordinated through the long COVID clinic, but they have sensory training. I can't remember what it's called, but the group at UW, the PMR group, they do a lot of that coordination with the rehab folks on sort of regaining your sense of smell. And I'm happy to share that information for that clinic. It's an adult clinic. I don't actually know what the pediatric clinic options are, but for adults, that's a good initial resource.
Curious if you notice any increase in migraine episodes for folks who have had COVID infections or long COVID.
I have not. I have not. I have seen people whose anxiety and depression have significantly worsened. Their baseline anxiety and depression, which has been well managed and well treated, with their long COVID has become significantly worse. We have a lot of I spend a lot of time talking to patients who are suicidal as a result of their long COVID. So yeah,
Wow.
so it's been it's really quite debilitating.
Yeah. Well, thank you so much, Dr. Chu. Thank you for your expertise and the work that you do. We are going to go to break now. I appreciate you.